treatment, whether the children need to be operated, and they cite this article, which basically says that in children, especially when they are operated late, lose the adaptive function that they have acquired over the whatever age they are being intervened at. And then the authors discuss that that's why we need data to share with the patient's relatives and to counsel them whether the surgical option is actually better or conservative management.
Hello, I can't hear anything. Nilesh is muted.
Nilesh, your voice went off in between. Can you start?
After the first slide, I think we should go back to it. Hello, I can't hear anything. Nilesh is muted.
Nilesh, your voice went off in between. Can you start?
After the first slide, I think we should go back to it. Hello, I can't hear anything. Nilesh is muted.
Nilesh, your voice went off in between. Can you start?
After the first slide, I think we should go back to it.
No.
Hello, Nilesh.
Nilesh by mistake exited the meeting. I think his.
Hello.
Yeah.
Yes, sir. Something was blocking my view, and I tried to get it out of the way, and I by mistake.
Now, okay, you start again then. Sorry.
Sorry, sir.
Yeah.
So I'll start with the. So you need to allow me to share screen again.
Yeah. You are the co-host only, Nilesh. You can. See again.
Yeah, now I can.
Yeah.
Yeah, sorry for that interruption. So as I was saying, the authors tried to generate the data to.
Nilesh, you need to go back. I'm sorry.
Okay.
You missed a lot of slides. Go to slide 3.
Yes, sir.
Slide 3.
Yeah, this is the slide 3. Yeah. Sorry about that. Yeah. So after enumerating the aims, what the authors say is there needs to be a data comparing the patients managed conservatively and patients operated. And there is an article which they cite, which says that if you operate patients late, they actually lose out on the function that they have adapted to over whatever course of years the children have lived with the deformity. And then there are some articles like this, which compare non-operative and operative treatment, but they are based on relatively fewer number of patients. So the authors are trying to generate a data comparing operated and non-operated patients on a bigger scale, on a higher number of patients. So they begin with a null hypothesis that there is no statistical difference between the operative and non-operative group, as seen on radiography and functional evaluation. They looked at their own data over a period of 19 years, that is from 1985 to 2004. And the inclusion criteria they selected were severe deficiencies, that is type 3 or 4 by Bain's classification, children operated by surgical intervention of centralization or radialization were assigned to group 2, and conservatively managed children were assigned to group 1. And all the children had to be available and willing for follow-up for at least a period of 5 years. So those were the inclusion criteria. The exclusion criteria were milder deficiencies, that is type 1 or 2. Children managed with some other operative interventions, and children who were not available for follow-up or with incomplete records. So using these criteria, they identified 486 children over a period of those 19 years, out of which 342 were fit enough to be included in the study. In these 342, 137 children formed a non-operative group, and there were various reasons for them being not operated, like refusal for surgery, or children who presented late after 2 years of age, or if they had severe associated congenital anomalies which prevented any surgical intervention. And 239 children with 309 hands underwent procedures of either centralization or radialization, and 145 excluded as per exclusion criteria. So the protocol followed for non-operative group was serial stretching to get carpus aligned to ulna, after which instead of cast, a brace was used and adaptive training was taught to the children. And mean follow-up period for this group was 10.1 years. In operative group, there were two techniques that were used. Till the age of 11 months, all the children underwent serial casting. After that, at the age of 11 months, the surgical procedures were initiated. 202 hands underwent centralization by a technique described by Dr. Manske, where ulnar physis is preserved, a carpal notch is created. 33 cases needed actually carpal resection, and a K-wire is passed across third metacarpal into the ulna with or without osteotomy. And after 1987, they added the step of ECU advancement also. 107 hands underwent procedure described by Dr. Bagramko, radialization, where the carpus is also preserved, and when radial sided wrist muscles are there, they are transferred on the ulnar side, and the K-wire goes from second metacarpal to ulna. In both cases, both groups, the K-wire is maintained till around 3 months, after which bracing is done for a couple of years, and 87 hands underwent the procedure of polycization. And mean follow-up period for this group was 11.1 years. There were many criteria used for assessment. So there was a subjective assessment in which a visual analog scale was used for pain and aesthetics, but the scale was of a 100-point scale rather than a 10-point scale, and the lower score is a better outcome. Objective assessment was done by measuring the resting wrist angle, the wrist flexion and extension arc, the long finger total flexion arc, and grip strength whenever possible. The radiographic assessment was done by using hand forearm angle, which is basically angle between third metacarpal axis and a line perpendicular to distal ulnar physis. A hand forearm position which measures the relative distance between distal end of ulna and fifth metacarpal base, and measurement of ulnar bow. A functional assessment was done using prosthetic upper extremity function index, which basically gives questionnaire for activities of daily living, and the higher the score, the better is the outcome. And various statistical tests were done to minimize errors and find significance. So after analyzing their data, what they found was on the pain score, the visual analog score was almost negligible in both groups. Aesthetically, the VA scores were lower in favor of operative groups. Hand forearm angle were lower in favor of operative groups. The wrist range of motion was higher in favor of non-operative group. The long finger range of motion, mean grip strength compared to opposite side, and PUFI scores were higher in favor of operative group. So except for pain, there was a statistical difference between the scores in both groups. It was only in the wrist range of motion where the statistical difference was higher or better in non-operative group. All other scores, the outcomes were better in favor of operative group. They also marked scatter plots, and the scatter plots indicated that hand forearm angle is inversely correlated to the function. The long finger range of motion is positively correlated to the functional outcome, and hand forearm position again is inversely correlated to the functional outcome. And in all those plots, the values are better in operative group than the non-operative group. The complications were mainly encountered in the operative group. There was significant ulnar bow formation in 19% of cases. There was recurrence of the radial deviation of the wrist in 15% of cases. And many of the patients in this group did not agree for surgery the second time. And there was a re-exploration after surgery in 6.5% of times because of various problems like venous congestion or doubtful circulation. The authors cite the limitations of this study as it being a retrospective study, which can induce a selection bias. They made their effort to try and reduce this bias. There was a significant attrition rate of 20%. The authors tell that the hospitals these studies were done where are tertiary care hospitals. So patients travel from long and it is not possible to get them back for follow-up. Some patients did not undergo polycization, so their functional evaluation can be confounded due to this. And finally, the PUFI score is not originally designed for radial longitudinal deficiency. It was originally designed for transverse deficiency, although there is validation of this scoring for radial longitudinal deficiency. So in discussion, they say that the null hypothesis is countered by the results. The appearance is less than satisfactory in both groups, but the scores were lower. That is, the appreciation in terms of aesthetics was better in the operative group. The hand forearm angle and positions when improved is likely to improve the functional outcome. A long finger range of motion has a strong positive correlation, whereas wrist range of motion has only moderate correlation with the functional outcome. Grip strength measurement and comparison is difficult, especially in children who are not operated. And ulnar bow is the predominant complication to be anticipated. So they conclude that surgical centralization or radialization seems to be associated with improved appearance and function. Thank you.
Thank you, Nilesh. Well presented. And Dr. Scott.
Hello. Good morning here.
Yes,
good evening to where you are.
Yes.
Thank you, Praveen, for the kind invitation. That article was certainly very well presented, and when it came out, it was certainly is and has been a very landmark article regarding radial longitudinal efficiency, because before that, and I think after that, no one's really been able to recreate those results, meaning that there's always been a controversy about whether a straight wrist is better than a just leaving them alone in a non-operative group. And like was presented, there's been several articles about if you leave them alone in the long history. The article from Ekbom in Sweden shows that there's no difference really long term. So this is an important article for those people or those surgeons that feel that centralization, or radialization, those types of procedures are what they treat their patients with. From our standpoint, we used to do that a long time ago, and we ran into problems with ulnar physis growth or ulnar growth long term. And I was curious because that was listed, it was in the aims, but I never saw any results in there as far as the ulnar growth long term. In a radial longitudinal efficiency patient, it's 2/3 of normal to begin with, and if you start notching things and work around the physis capsule, it seems that you may end up with a really short form. But I don't know that because I didn't see that data in there. I do think it's important, and it does support the people that do like to do radialization or centralization. Since I don't really have comments about it. I just know that we published our own data on, just doing soft tissue procedures around it and had very good results in those children. And a lot of them do use the wrist motion, whether it's flexion extension or sort of that radial deviation they have to actually grab things. So for our patients, that seems to be important.
In your practice, do you think there is any indication for non-operative treatment, or is there any spectrum of patients where you tell, okay, we will manage this non-operatively, or in other words, are there any relative or absolute contraindications for corrections in your practice?
Yeah, I don't think there's any contraindications to it. It's just a matter of, your philosophy on whether a straight wrist is better than a wrist that's left into its radial deviation. We offer procedures too, because what I like to do is I sort of stretch them just like they did in that non-operative group. I'll stretch them in about the age of 5. I offer them a Wilkie procedure, which is taking a vascularized second toe and put it up there. And it used to be, maybe 60%, 50% were interested in it. Now it's pretty far down. It's down to probably about 10% that are interested in it because the kids function so well, with the wrist just being in its, position that's going to be, whether it's 50, 60, 70 degrees of radial deviation.
We remember your talk about merry-go-round.
Yeah.
And then that second toe transfer is the best
exactly.
one.
But
Okay.
so I think it's a philosophy, and I think this was a fantastic article. I commend the authors for getting that kind of follow-up. And we have problems getting follow-up in our patients that are all usually from one state. And just visiting you guys down in Ganga and seeing where they all came from, I find it's unbelievable that they could get all these patients back from around India, which I imagine they came from. So the authors, I thought it was a very nice paper to add to the literature and really supports people that decide on centralization or radialization. I would also be curious to see what happens long-term, because it was, they had a nice follow-up, but at skeletal maturity, how much radial deviation do they have in recurrence?
One of the common things, especially in exams, when we are discussing the case of a radial club hand, one of the things examiner always says, if the child does not have elbow flexion, we must not do correction of the radial club hand. Do you believe in that?
100%. I should have mentioned that, because that's what is absolutely true. If their elbows are stiff and they don't have good motion, you probably shouldn't do anything, because they definitely will use that radial curve of their wrist in terms of daily function.
So before we open the questions to everyone, one other thing, sir, what is your indication for doing polycization? At what degree of deviation you think that polycization would not be useful?
That's really up to the patient. Actually will show you that, because what I do is in clinic, in my lab coat, I have a bunch of little toys, and it looks like I'm just playing with the kids. But really what I'm doing is I have small toys and I have big toys, and I give it to them, between the age of 1 and 2 or 1 and 3, and I see how they grasp. So if their prehensile grasp seems to be between the index and middle finger, I would offer it to the patients or to the parents. And if it's really ring and little finger, which many of these kids are, then I would not polycize them, because I don't think they'll use it.
Okay. And your preferred age?
For polycization? Is that what you mean?
For correction of the radial the deformity and then polycization.
Okay, so what I usually do is if they have a really tight wrist contraction radially, like 90, 100 degrees, I offer the parents a soft tissue release at about a year of age, or 18 months, somewhere in that range, 12 to 18 months, because that will get their wrist out nicely, so they have some ability to go ulnarly. Certainly it's not going to get corrected to neutral, but there's some ability to get out of that severely contracted position. And then about 18 months to 2 years, I'll do a polycization.
18 months to 2 years. Okay, thank you. That is, sir.
Yeah.
Any comments from you, sir?
No, thank you, Dr. Scott Oishi. I have a question for Nilesh. Nilesh, in this, is Nilesh able to hear me?
Yes, sir.
So in this paper, did they polycize the non-operated group as well, or they did not?
So they have not specified, but the impression I got is the non-operative group didn't get anything.
In which case that prosthetic upper limb score will be vastly different, right? Shoelaces and everything, if there is no polycization. So that is another confounding factor then.
And they mention in operative group also, not all children who could have gone under polycization actually consented for it. So in that confounding factors, even the authors acknowledge that the children who didn't undergo polycization is a drawback of the study.
Right. Our paper for almost a 16-year follow-up now of a 2-stage procedure of distraction followed by radialization. He's accepted in JHS American, and we've got 69% growth compared to opposite ulna in our rather small cohort. But we got the same growth at a 5-year follow-up, and we are getting the same at a longer-term follow-up. So the growth is not a problem, although wrist mobility is a problem. We get a wrist mobility of 5 to 10 degrees total.
But if we try to get too much of wrist mobility, it would also invite instability.
Yeah, true.
So maybe reducing movement is providing some.
Well, we are not reducing it, it gets reduced. I think we brace all our children till the age of skeletal maturity. That also might be contributing. And one more question I had, Nilesh made a comment that ulnar bowing was caused by surgery.
No, sir. So the ulnar bowing, I mean, it's not very clear in the article, but I think it is the ulnar bow was made, rather the ulnar bow was more apparent after the procedure of centralization and radialization.
Yeah, because
or even if it,
the ulnar bow is caused by the persistent pull of the common flexor origin. At least that is what I think. I don't know what Scott thinks.
Yes, I think I agree with you 100%. I think, more and more data is coming out. There's a group in England that talks about abnormal muscular tenderness or abnormal muscle in the forearm. And I certainly think it's that abnormal pull because the muscles, we talk about the bone, but it's actually the whole forearm. So in that forearm, when they looked at the muscle, it's actually a different type of muscle and it's much tighter than other types of muscle. And I think that data is coming out pretty soon in the European Journal, I believe, because they've been talking about it for a while, the group out of the UK.
And Scott, do you treat ulnar bowing with osteotomy or you don't?
If we go ahead, if we do a Wilkie procedure, we do, because when we distraction lengthen them, we usually will try to cut the ulna at the same time if they have a significant bow.
Mm-hmm. But let's say you notice some at 7 years of age, will you do an osteotomy?
Yes, at 7.
Yeah.
If we're going to do a Wilkie, yeah. But I agree with you 100%. I think it's not. I saw that too in the paper, and I was not really clear on how doing centralization and radialization would cause the ulnar bowing. Because I agree with you. I think it's more inherent to what the forearm is in the musculature rather than being as a result of that procedure. So I think your point's a very important one.
Yeah.
Do you routinely do a distraction before you correct the the club hand, sir?
You're asking me?
Both of you, sir.
I always do a distraction.
Dr. Scott?
Yeah, before we do the Wilkie, we certainly do a distraction, because if you look at especially when they get to be 5 or 6, if you look at the form, and it's not just the one, the hard thing about anybody that's done it knows it's very difficult because it's not just one plane. It's not just the radial ulnar plane, because the carpus is also forwardly sublux. So the distraction has to be dorsally as well as ulnarly. So it can be very tricky because you're really correcting 2 planes, not just one. Even though we think of it as one plane, it's really a 2-plane correction.
Actually, the carpus is overriding the tip of the ulna. And unless you distract it away from the tip of the ulna, you will never be able to centralize or radialize.
Is that at what age are you doing them at? Is that at even at an early age? You just
I started between 6 months to 12 months.
Mm-hmm.
So one question.
I think that's certainly what most people are doing. Most of my friends that are in Europe that do radialization centralization feel very strongly that pre-centralization distraction, like you're talking about, is very important adjunct to that procedure. Yeah.
Okay. And thank you, sir. Thank you, Dr. Scott. Thank you, Tate, sir. So a few nice points what we get from this article and the discussion what we had after that. One is the radial club hand is worth treating. So non-operative treatment is not that much of a good thing, though many times the recurrence is so severe. If not treated properly, you would feel that maybe we have not operated, then it would be better. But if done properly, the operative treatment does give good result. So the age at intervention should be early. That is told at 6 months he starts doing correction using a distractor. And so radial, the deviation could be corrected somewhere around 12 to 18 months. And 6 months after that, we can plan to do a polycization. And if done well, these children would do well. And the length, they grow to around 60 to 70% of the normal. So with all this good information, what we have learned, we go on to the second article.
Praveen, there is one question by Dr. Manjunath.
Yes, sir.
I have not understood the question. It says brachiocarpalis. I don't know what he means.
Yeah, so what he's talking about is we published in the kids that have TAR. So specifically in kids that have TAR syndrome, they have a muscle called the brachiocarpalis. So what we termed it that because it's like a brachioradialis, but instead of starting in this normal position, it starts very high in the humerus. It originates, and we found it just in the TAR kids, and it causes wrist deformity as well as elbow deformity. And sometimes releasing that muscle can help you correct the radial deviation at the wrist. So that's what he means by brachiocarpalis,
Right.
and it's specifically to what we were talking about.
I learned something. Good, thank you.
Yeah.
So, Dr. Nilesh, you want to ask some question? Yes, Nilesh.
I was looking for some images to use, and while doing that, I came across something like ulnarization by Dr. Pally. I have no idea what it is. Any light on that? So
no, I would say so. I've seen several of those patients because he works in the United States. He'll argue that that's the procedure. He basically takes the carpus and throws it over on the ulna side of the ulna. The couple patients I've seen is sort of a second opinion there. He gets total growth arrest, not much motion. Even though the wrists are straight, they're very short with very, very little motion. But that's just my gestalt about it. But he will say that they stay straight and they continue to have some motion because he sort of makes a pseudo joint off the ulna side of the ulna. But basically he's distracting and then putting the carpus on the ulnar side of the ulna. So just completely just transposing it and not trying to stay on the ulna, just going to the other side of the ulna. And that's what's called this ulnarization procedure.
thank you, sir.
One of the visitor we had in the department from Ukraine. Ukraine is in problem these days. She was from Ukraine, and she was presenting and intentionally trying to create a chondrodesis and make the wrist totally straight, just because of repeated recurrence. And they told that they are getting good result with that. So wrist does not move much, but it remains straight and it looks nicer.
Yeah, although they I don't know, they have a high incidence of hurting the ulna physis for sure in that procedure. So you may have a straight wrist, but it's very, very short and doesn't move very much. And so the argument is always, is a straight wrist better than a straight short wrist better than a wrist that has some deviation to it?
So they were presenting that they chondrodes, let the wrist be short, and after 4 years they distract and lengthen the forearm. She was showing long-term results. They looked quite nice.
Oh, good. That's interesting procedure. Again, the muscles are abnormal in the forearm, and I think distracting and trying to make it longer can oftentimes make the finger stiffer. But interesting.
Yeah, but I have not seen the publication, but on presentation it looked nice. Maybe I will contact her again and ask what is the follow-up over a period of years. Thank you, sir. We'll go to the next paper. And Dr. Selva?
Praveen, I'm there.
Yeah, please share your screen.
Yeah.
So the next article would be again another interesting comparison between graftless and graft technique for syndactyly release. And Dr. Selva, over to you.
Yeah, able to see my screen?
Yeah.
Yeah. Good evening, all. And thanks for this opportunity. Thank the ISSH academics. And so this journal is about a comparison of syndactyl release with the skin graft versus graftless techniques. And this article was published in the Journal of Hand Surgery European volume in October 2019. The authors are Angela A. Wang and Douglas T. Hutchinson, both from the Department of Orthopedics at University of Utah. So just before going to the proper article, actually just we'll have a little bit of background of what the article is going to about. Actually, I mean, we do syntactic release has been done to maintain two things. One is a finger separation and the web space reconstruction. So these are the primary goals of syntactic release, and this has been, there are many described methods of syntactic release. The most common surgical technique is using a proximally based dorsal flap with a zigzag finger separation to prevent a scar contracture. So majority of some cases require a skin grafting. So what could be the reason? Because the proximally based dorsal flap typically extends into the proximal phalanges of the fused digits. That's why stealing a part of the skin from the dorsum of fingers, and the surface area of the separated fingers will be approximately 25% more than that of the syntactalized digits. So for these reasons, there is a need for a skin grafting in such cases. So there are more recent descriptions of graftless techniques that have allowed surgeons to avoid a skin graft. But neither type of release has been clearly shown to have a consistent benefit over the other. So with this background, this authors has made this the purpose of this study is to examine the long-term appearance of releases carried out in patients with bilateral symmetrical syntactically. That's the most important one, because they have to eliminate a lot of confounding factors. So comparing hands in the same patient would eliminate the factors like genetics of scarring, different post-operative protocols, socioeconomic status, and they mentioned as distance of travel conditions. Probably the post-op follow-up, if they're close, they may have a frequent follow-up. So it is an institutional review board approved study from 2004 to 10, and all patients were bilateral, symmetrical, and included both simple and complex syntactically, but more commonly were simple. And the randomization was done using the medical record number. So if a patient has an even number, then the right hand was treated by grafting, and the left hand was treated by a graftless technique, and vice versa. So the contralateral side was done with the graftless technique at the same surgical session. So what the method followed by the authors. This is the method, a dorsal rectangular flap technique. And for the graftless technique, they have done what described by Sharif et al. In 1998. But in the volar side, it is the same zigzag incision. So actually, in the graftless technique, they use the dorsal island flap, which they advance into the web. I will just show. So they have the dorsal island flap, which was advanced into the web. So the author described that there was no learning curve with either skin graft or graftless techniques, and neither surgeon had any preference for one technique over the other. And the full thickness graft in all their cases were obtained from the ulnar side of the hand, because they preferred that there's not much hair. And the postoperative dressings were identical on each side, but included plaster splints, soft dressings, or an elastic tape. So they have a postoperative visits at scheduled intervals, and at each visit, the following parameters are measured: the web creep, the scar scores, and the web space abduction. Apart from that, they had the visual analog scale measurement done by the patient's parent, a single surgeon, and the hand therapist. So this is the scale which they use for assess the scar quality and the web creep. So lower the score, the scar is better. Similarly, lower the score in the web. I mean, if it's 0, then it's a normal web, which is similar to that of the uninvolved web. And when the number score increases, it has a more of web creep. So the result, there are a total of 14 patients, and they, as per their study, the statistical analysis for their requirement, they require a minimum of 14 patients. So initially they had 16 patients, and 2 of them are lost due to follow-up, and they had 14 patients. The mean age of surgery is 27 months. Range is 7 to 166. And the mean follow-up was 52 months. There were 10 boys and 4 girls in the study. And the 12 were simple syntactically and 4 were complex syntactically. And the third web space was the most commonly involved. So the 3 patients required revision syntactic surgery owing to scarring and creep, in which the 1 was the skin grafted side and 2 was from the graftless side. all the results what they have mentioned in this study are only up to the point of revision surgery. They never included beyond the revision surgery. This is one case in which they have done the graft and there was a contraction between the in the third web space, so which was later released. This is a 11-year follow-up of the same patient. So these are the parameters which they considered between the graft side and the graftless side. So first is a tourniquet term. Obviously, that in the grafted side, the tourniquet time was higher, significantly higher because of the time taken to insert the graft. So web creep, if you see the web creep is less in the grafted side, and in the VAS score by the surgeon and the therapist, they are actually in favor of the graft side compared to the graftless side. But the mean finger abduction, the scar, and the VAS scores for parents were not significantly different between the two techniques. So traditional release of syndactylis usually involve the use of a full thickness skin graft, and the advantages of using grafts include the availability of abundant skin, the supple nature of a full thickness skin graft, and the less tension of the closure and less graft contracture. But the disadvantages include the morbidity and cosmesis of an additional incision, the time needed to insert the graft, as we have seen that the increased tourniquet time, and the groin graft, which changes in color and hair growth with puberty. Though they have described this, the authors in this paper have not used the graft from the groin region. So in graftless techniques, it was first described by Dr. Niranjan and D. Carpentier in 1990. They described the dorsal trilobed flap. And then Sherif in 1998 used the dorsal metacarpal. Sorry, is there some later? Sorry. Yeah, described the dorsal metacarpal island flap, which was advanced into the web space and along with the thorough defatting of the fingers. So this was a technique which was followed by the authors in this article. And the advantages of the graftless techniques were obviously there are no donor scar and the less operating time. And the disadvantage is the visible dorsal hand scar from the advancement of the flap. So the author describes 3 literature study in this article. The first is a systemic review of 34 articles. Most of them were simple syndactylis. So here the conclusion is the skin grafted fingers were associated with more complications, but there was no randomization in this study. And the next 2 studies were the retrospective studies. The first one is by Yuan et al. Including 45 patients. They analyzed 18 independent raters looking at standard sets of photos. Here they conclude that a skin grafted fingers had statistically significant better visual analog scale scores. And the third article is by the Ferrari and Worker, which is again a retrospective study of 27 patients. Here the patient observer scar assessment scale, the Withey score, and the satisfaction survey was included. It concluded that the patient rated satisfaction scores were similar in both groups, but the prevalence of additional surgical procedures was higher in the skin grafted group. But in further explanation to this additional procedures, the author mentions they do not have enough data to see which procedure may require more revision surgery, and also revision surgery may not be a valid outcome measure as variables such as the desires of patients or parents, the surgeon bias, and a change of surgeon may all play a part in the decision for revision. So they are not included revision in this assessment. The strength of the study is a clean comparison of graft versus graftless technique by comparing bilateral hands in the same patient. But the limitations are obviously there's a relatively small number of patients, there's only 14 patients, and a presence of slight variability in the types of syndactyly, and the graftless techniques that leaves a fairly noticeable dorsal hand scar, and patients have not been followed to skeletal maturity. One more point which I noticed is the age difference, because they have operated from 7 months to almost 13 years. So a lot of, the huge difference in age group in the study, which also can confound the results. And conclude on multiple parameter analysis, that is the scar, web creep, and the visual analog scoring, The study demonstrated a slight aesthetic advantage with the use of traditional full thickness skin graft over graftless techniques for syndactyl release. Thank you for your patient listening.
Thank you, Dr. Silva. Nicely presented. Dr. Scott, your comments?
Yeah, I think that was a very nice summary. Very nice job that you did on that. The controversy has always been, or more recently has been, should you use a skin graft or no skin graft? We would, if it's only a small, simple syndactyl that may be just short of the PIP joint, it's intriguing, and I would think about using a graftless technique. But as you can see, the dorsal scar is pretty unsightly in most of these techniques. And it's, although there have been articles that have shown that there's not much difference between which one you do, whether graftless or using a skin graft. I tend to use skin graft all the time, and I take it from the volar wrist because I think that has a good color match, and you don't run into problems with the hair, especially in even the hairiest male. If you look at their forearm or if you look at their wrist over the volar ulnar side of their wrist, you never grow hair. So that's a great site to take it in, even in males that have a parent or a father that's very hairy. The more intriguing thing I think nowadays is, I don't know if you've heard about it, but people are releasing them and not using skin graft, but just putting hyaluronic acid sheets along the sides and removing them after 3 weeks and just letting it granulate in. I think that data is very mixed also. I have not tried it personally. Some people do it. I've reviewed an article recently that talked about the high percentage rate of sort of scarring and wound healing problems when they're doing that. So I think you got to be careful and, sort of consider maybe trying your own practice about this hyaluronic acid. But I think that this was an important article because it basically shows that it can support either way. If you're a grafter or a non-grafter, you can get support from this article.
So you are basically trying to tell that you always you do a graftless technique only when it is easily coming. Otherwise, you don't strive for it.
Correct. I don't. I think, we've had great results with the graft. And it's hard for me to change it. It doesn't, I think it takes, what they say, 13 more minutes of tourniquet time. So, for us, it's always worked better. So
can I ask a question?
Sure.
So pre-operatively, will you decide whether to go for a graft or a graftless technique? Do you have any idea, or intraoperatively, so that you can change the plan of the flap or the incision? Do you have any idea pre-operatively?
If we're going to do graft or graftless, is that what you mean? Yeah. So I'll discuss graftless if the webbing goes out, those ones that just go a little bit short of the PIP joint, then I think the graftless is, you're just doing sort of that metacarpal island flap. I think it starts to get dangerous when you do that and start defatting all those flaps along the side, because, you run the risk of sort of either getting contraction or even flap loss, which can lead to more scarring. Yeah.
Yes, one similar question has come on the chat box, which says that you have put a graft over there and you have a graft loss. Then what do? You put a partial thickness, or again, you try to go and put a second full thickness, or you allow secondary healing?
Well, initially, we always allow secondary healing. So usually we're doing these at about, 18 months of age. We used to do them earlier, but now because of the anesthesia potential risk, we try to wait till they're close to 18 months to do the syndactyl releases. But when they come back, and we put them away in a mitten cast for 3 or 4 weeks, and they come back and they have some skin graft loss, because every once in a while they do, we treat it conservatively and let them heal and don't go right back.
And Thate sir, your comments about article and your preferences for that?
I think it's a nice article. Like Selva said, it's a clean comparison. Numbers are very small.
Yeah.
But I think we need to consider a more fundamental point of wound biology. And number one, we need to acknowledge that the geometry is for grafts. The size of one ellipse covering 2 joint fingers is always going to be smaller than 2 circles of 2 separated fingers. So like Selva pointed out, there is a 25 to 30% shortage of skin. What people do with graftless technique is 2 things. One, they reduce the volume of the finger by defatting, and therefore the same amount of skin is now adequate to cover. And two, they are importing from the dorsum of the metacarpal flap, and therefore the net defect that would be caused by using the top of proximal phalanx flap is now being compensated. That is, from a conceptual point of view, that is what the graftless technique is, which means you need to have very high degree of technical competence to do that defatting safely without causing neurovascular damage and without causing a potential flap loss. On the other hand, if you put a graft, a full thickness graft, I think you are safer in some ways. I'm a little wary of the graftless technique. So unless, you know, a child is slightly older and the fat content is much lower, then you get good planes in which to defat safely. In chubby kids 18 months of age, the plane is not very clear and it's quite unsafe technically to defat it. The other, I have a question, I don't know if Scott can answer it. People say that this dorsal flap we take should have a concave tip like Selva showed in his designs, and that the concave tip reduces web creep. I haven't ever been able to understand the geometrical or the wound biology basis for this concave tip reducing scar creep. That's the claim.
Yeah, I don't know either. I really don't. I think it may be because where they inset the flap will cause more of that web creep. I agree with you. I've thought about that too. I mean, I'm not sure what the concavity versus a convex,
or a straight line for that matter,
or a straight line. I think it matters more where you inset. You know, you always want to advance it more into the palm than you don't want to inset it right into the web.
Yeah.
So I think that's leads to more of the web creep problems. But I agree. I don't understand that.
Yeah.
So they always have, like regarding the web creep, also they mention about the intermetatarsal ligament release. So what's the point from
intermetacarpal ligament release? Oh boy,
yeah.
I never do that one.
Yeah, I don't either. I saw that too, and I was I know those two very well. I don't know where that came from, intermetacarpal release. I don't know, except if they're trying to get the web deeper, you know, and advance it into that area. I don't know why that was in there. I don't know.
Selva, I have a question for you. I didn't understand this ulnar border of the hand graft, which means they take split thickness graft from the hypothenar eminence, or what?
No. So I think from the border, they have not mentioned specifically, probably in the ulnar border where it is in the skin, palmar skin junction, that area, sir. Probably in this area they are mentioning.
Oh, okay.
This area.
I do the wrist crease just like
okay.
Scott was.
Well, actually, I was also thinking, see, taking in the ulnar border, because that is the contact surface whenever you keep the hand, can lead to a painful scar. It is, but though it's a hairless, but that is usually the contact surface for all of us when they keep the hand.
Yeah, I was wondering if they wanted glabrous skin, which is why they are taking from there.
No,
yeah, I can't imagine that. I can't imagine they would want glabrous skin in there. I mean, we sometimes use that. We sometimes use that skin for on the tips. If we're not doing a buck Gramco flap, we'll use that composite graft from the ulnar side of the hand to put into the tip of the finger. But that seems like it would not look very good for a skin graft at the base of the finger.
Yeah.
Regarding the glabrous skin, we had a Japanese surgeon who was taking a graft from the inset, and he was very precisely fitting over there, telling that it will have a better skin match. Do you do that
of the foot?
Yes, sir. So he's telling that skin match will be nicer. And Nilesh, you have some question? You raised hand. Ask, please.
The same thing, actually. The last Ganga operative course. I just wanted to ask anybody doing that. It was an interesting thing to see. Japanese.
Yeah.
But actually, you know, the web is not glabrous skin. So why would you put glabrous skin in the web?
Yeah.
Yes, sir. So he took the skin from there. And he was, no, sir, when you are separating the web, half of it is glabrous and half is non-glabrous. So he was very precisely taking from the junction of the instep where a glabrous and non-glabrous comes, and very correctly matching that half of it would come to dorsum and half come onto the volar side.
Oh.
And it looked very nice, actually.
Okay.
Yes, sir. Sir, or in your experience, did you find any the effect
Sir, sorry to interrupt, but this Zoom link has.
No, shut the fuck up. It's not been bombed.
Sir, 8 minutes, sir. The link someone here, I can show you. It's by someone called Charles Oliver. That's Charles Oliver
Shut the fuck up, L.
your
Go,
Zoom
go.
link.
Shut the
Sorry
fuck
to
up.
interrupt.
Just go. Shut the fuck up.
Sir, 8 minutes, sir. The link has been sent on Twitter, sir.
What is happening right now?
What was that?
Hello.
There is a kid somewhere.
I have muted all. Even then, it is that kid is not going away.
Bro, shut the fuck up.
Dong, 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 dong.
Sir, 8 minutes.
Help me.
Oh, where can my
Sir,
baby
link.
be? I'm a gang, and I'm pulling up. Got these
is being
bitches on there.
If something tells me
Praveen, we have been hacked. You see the comment attributed to Scott in the chat box.
Hello.
You are muted, Praveen.
What if we restart?